Good morning. Welcome to the Westminster Presbyterian Church Social Justice Forums. My name is Ken Jocelyn, and I'm a member of the Social Justice Forum mission team. Our theme for this year is Wade in the Water, Becoming an Anti-Racist. Today we have Melanie Ferris of the Wilder Foundation, and she's going to focus on the intersection between racism and health inequities. When I asked Melanie how she would like to be introduced, she said, well, I'm a lifelong Minnesotan, grew up in a small town, live in the Twin Cities. I'm a wife and mother of two young daughters, and that colors how I see the world and the kinds of things I work on. She is the Strategic Initiative Lead and Research Scientist at Wilder. She's not only a researcher, but as you'll hear, she is clearly committed to actions that make the world a better place for all of us. With that, Melanie, it's yours.
Thanks so much, Ken, and thanks everyone. I thought as I begin, it would be helpful for me just to say a little bit more about me and why I, a white cisgender researcher, am here to talk with all of you about racism and health inequities. I don't study racism per se, and frankly, because of the privilege that I have, I don't have to experience daily racism and discrimination. But I think to do research in the field of public health, I really need to understand racism and how it influences health, because pretending that we all have the same opportunity for health is a false starting point. And so I see my responsibility in this field to both further amplify the work that's being done by researchers of color and to keep having a conversation with people like myself who are white, who have privilege, because we have a responsibility for recognizing and working to change the very systems that frankly have given us unfair and unearned opportunities. My presentation kind of covers four main areas. I'd like to talk with you all about what health inequities are, about the factors that shape our overall health and well-being, and then really spend some time talking about what structural racism is and how that leads to inequalities. And finally, inviting you to think about the next steps that can be taken. As I start the presentation, I'm going to tell you that what I'm about to share isn't necessarily new. I mean, I'll certainly highlight some new data points and timely information, but there are decades upon decades of data that show the myriad ways that racism drives health inequities. What I hope to do in this presentation is to deepen your thinking about the ways that racism contributes to health inequities. And by the end of this presentation, I want all of you to be able to recognize that we can't talk about health inequities without also talking about the impact of racism and the necessity of changing unjust systems. So as I begin, I first want to be really clear on my definition of health inequities. Health inequities can be defined as avoidable differences in health between groups of people that result from systematic differences and social conditions and processes that determine health. Health inequities are avoidable, they are unjust, and because of that, there can be actions to eliminate health inequities. So said another way, there are differences in health outcomes that we would expect to see. For obvious reasons, rates of breast cancer are higher among women than among men. This is an expected genetic difference. But when we talk about differences in health outcomes by racial group, we are not talking about differences by race. We're talking about differences due to racism. So the purpose of this presentation isn't to inundate you with data points describing inequities, but I do want to provide some broader context for the presentation. In 2017, the life expectancy of Black males in this country was 71.5 years, and that's roughly 5 years less than for white males. And while the average life expectancy for Black women is closer to the national average at 78 years, that's still approximately 3 years less than for white females. Now, these kind of inequities are evident across the lifespan, from birth, where we see in Minnesota that the rate of infant mortality is twice as high for babies of Indigenous and Black mothers as compared to babies of white mothers. We see how it impacts when illnesses are diagnosed and how they are treated. For instance, In Minnesota, Latino and Black women are more likely to be diagnosed with late-stage breast cancer than women of other racial groups, showing delays in preventive medicine or early diagnosis. Similarly, Minnesota Community Measurement, which looks at health outcome and quality data across clinics and hospitals in the state, saw that Black, Indigenous, and Latino patients are less likely than white patients to receive optimal care for a variety of conditions, including diabetes, asthma, and depression. We even see inequities at the end of life. We know that among Black, Asian, and Latino individuals, they're less likely than white individuals to receive hospice care. Now, there's a number of factors that contribute to whether people choose to have hospice care in their final stages of life. But one of the things that was brought up in this study is that a reason that people didn't choose hospice care is because they weren't certain that they would receive the compassionate, high quality care that they wanted in their final days. Now, we might assume that these differences that I talked about are just simply due to disparities in healthcare access. And it's true that there are disparities in health insurance. This graph that I'm showing from Minnesota Compass shows that in Minnesota, 5% of all residents under the age of 65 are without health insurance. The rate is lowest among Minnesotans who are white. 3.1% do not have health insurance. But rates of uninsurance are nearly twice as high for Minnesotans who are Asian or Black. And among Hispanics, the rate of uninsurance is 6 times higher than for whites. But health inequities are not simply an issue of whether or not somebody has insurance. At multiple points in a patient's healthcare experience, provider bias, existing policies and practices, and structural barriers can lead to unequal care. Multiple studies have shown that when treating Black patients, providers tend to spend less time with their patients, misinterpret or dismiss complaints, and undertreat pain as compared to treatment of white patients. This understandably leads to delays in identification and treatment of disease, poor quality care, and poorer health outcomes for Black patients. And although I've started with healthcare, access to healthcare insurance and the services provided through healthcare are only a small part of what actually contributes to our health. Multiple things influence our health and well-being. It's our access to healthy food. It's our connections with others in our community. It's being able to live in places where we have clean water and clean air. It's having public transportation so we can get around to the places where we need to be able to go, and making sure that we have an education system that works for everyone. These factors are called social determinants. And more simply put, they're the conditions in which we live, work, age, pray, and play. And as noted on this figure, you can see that healthcare, again, while very important to our health overall, being able to access healthcare and the quality of that care really only accounts for about 20% of our overall health. And it's these other social determinants, education, employment, the supports we have around us, socioeconomic status, feeling safe in our communities and connected, those matter much, much more to our overall health than healthcare does, and influences our opportunity to be able to access resources that support our health, and then the health behaviors that we're able to use in our regular lives. I want to spend a little bit of time really talking about socioeconomic status, because socioeconomic status is a key driver for health inequities, and it's easy to understand why. Without an adequate and steady income, people are forced to make difficult and no-win decisions about which basic needs to prioritize. Is it paying for rent or purchasing healthy foods or buying medications? There's no simple and easy choice. In Minnesota, there are notable socioeconomic differences by racial groups. And so I just want to share a few data points that illustrate this. This graph shows poverty rates by racial and ethnic group in Minnesota. And federal poverty levels are measured in a range that is based on family size. So in 2019, the federal poverty threshold was nearly $26,000 for a family of 4. So when we look at poverty as a percentage of the population, poverty rates are lowest among white Minnesotans, with about 7% of white Minnesotans living at or below the federal poverty line. Poverty rates for other racial and ethnic groups in Minnesota, though, are 2 to 4 times higher. And approximately 30% of American Indians and just over 1/4 of Black Minnesotans are living at or below the federal poverty level. We can also see a similar pattern in home ownership rates. Home ownership has traditionally been seen as a path to wealth generation. So particularly before the 2008 housing bubble and recession, owning a home created a stable asset and an opportunity to be able to pass resources on to the next generation. In Minnesota, 75% of whites are homeowners compared to 25% of Blacks and 40% of American Indian and Hispanic Minnesotans. And finally, again, when we look at household median income levels are roughly twice as high for white households compared to American Indian and Black households. And again, this is a reflection of both employment status and job quality, a combination of overall wages and total hours that are available to work. Now, we can look at the data points that I just described and conclude that we need more higher paying jobs and more funding for education. And frankly, those would be good steps to take. But we also have to recognize that just adding more resources to systems that are currently producing inequities without making changes in how those systems operate will not eliminate the inequities that we see today. Health inequities don't just exist at random. They happen because systemic racism is built into our social, economic, and political systems. So again, let me start with a couple key definitions. Racism has multiple forms. An individual racism may be what we first think about. An individual's assumptions, beliefs, or behaviors that stem from unconscious or conscious personal prejudice or bias. This might come in the form of racial slurs or something that is much more subtle. In contrast, structural racism is the work that happens within sectors and within organizations. It's defined as the normalization of an array of dynamics, historical, cultural, institutional, and interpersonal, that routinely advantage white people while producing cumulative and chronic adverse outcomes for people of color and American Indians. So to attempt to provide a illustration, individual racism may show up as a hiring manager's bias in deciding to favor a white candidate over a Black candidate, or think of a white candidate as being a better fit, even if the candidate who is Black has better qualifications. Structural racism could be seen if an organization's hiring processes put greater value on personal connections than what's actually in a resume or what happens through an interview. Or if a lot of weight is given to volunteer experiences or unpaid fellowships or low-wage assistantships, which are most feasible for college students to be able to do if they have additional financial support from their family, which gives some favoritism to families who are already affluent. So if we really want to think more deeply about what contributes to inequitable health outcomes, we need to think certainly about all the social determinants, but also recognize that within each one of these social determinants, education, access to healthcare, housing, work and economic opportunities, social conditions, the sense of social cohesion, there's underlying structural racism, and that influences every aspect of every social determinant together, adding burden upon burden to communities of color and creating a wider opportunity gap that benefits people who are white. So to go a bit deeper into this, I want to tie this whole conversation about structural racism to a study we did about a decade ago. We did a study in 2010 to more closely look at the connection between health outcomes, race, place, and social determinant status. So the map that you see is a map of the Twin Cities Metro. The areas shaded with the lightest blue color are areas where there is the longest life expectancy, an average of 83 years or more. And the areas that are kind of shaded in the darkest navy blue are areas where average life expectancy is lowest. And it's a little bit difficult to see where those neighborhoods are, but essentially it's neighborhoods in the central cities of Minneapolis and St. Paul, in neighborhoods that include North Minneapolis, the Phillips neighborhood, the Frogtown neighborhood in St. Paul. Now in this study, when we compared health outcomes by neighborhood median income, we found that there was an 8.4-year difference in average life expectancy between residents in the least affluent neighborhoods in the Twin Cities and those in the most affluent. And further, we saw that there was this clear health gradient showing that as average household income increased, so did life expectancy. We also learned through the study that life expectancies for racial groups in the Twin Cities range from highs of 83 years for people who are Asian to the lower life expectancies of 74 years for people who are Black in the Twin Cities and only 61 years for American Indians. And in our analysis of this data, we saw that the racial disparities were not explained away by socioeconomic status, and that instead, even at the highest income categories, while the racial disparity of life expectancy wasn't as wide, it persisted. So the pattern in this type of study isn't unique to the Twin Cities. Similar types of studies have been done in other parts of the United States, and they show similar results. And so to understand, again, how the connections between race, place, and socioeconomic status occur, part of that is looking back at the policies and practices that shape the neighborhoods that we have today. Housing covenants were one type of overtly racist policy that shaped neighborhoods in the Twin Cities and in communities across the United States. Housing deeds would include language such as, these premises shall not be sold, mortgaged, or leased to or occupied by a person or persons other than members of the Caucasian race. Incredibly explicit that it was creating this covenant to exclude people of other races and sometimes other religious groups. And while these covenants have been legally unenforceable for more than 70 years, we see the impacts of these policies today. In many ways, the New Deal era federal regulations of the time solidified some of what began through the racial covenants. So redlining was a practice that started in the 1930s, and that's where many banks in the United States were able to use this strategy to deny mortgages to people who lived in neighborhoods that were considered riskier neighborhoods to lend money to. It created denial of mortgages to people, mostly people of color in the urban areas, preventing people from being able to buy a home in certain neighborhoods or being able to get a loan to renovate their homes. Now, neighborhoods that were predominantly white, and that includes areas where racial covenants were already in place, were in some ways rewarded with the best credit ratings, making it easier for residents to purchase or renovate homes, creating an asset that generates wealth. Now, these policies are historical, but we still see the impacts today. The map that's up on your screen is a map of Hennepin and Ramsey counties. The blue areas that you see are the areas that were defined as red line districts, areas where banks essentially wouldn't loan to. And the people who lived in these areas, often people of color, again, were refused loans because of where they lived. Now, in this project where we did this mapping, we looked at these redlining districts, and then we also overlaid where there are currently areas of high concentrations of poverty, where at least 30% of residents in a neighborhood are earning, what is today less than $26,000 for a family of four. So the areas that you see on the map that are shaded with kind of the orange diagonal stripes, you can see that they almost exactly overlay where the red line districts were identified decades ago. So these policies contributed to both socioeconomic and racial inequities. And the map, again, that I'm showing now shows how these also have contributed to segregated neighborhoods. Again, this is a map looking at Minneapolis and St. Paul, and you can see where there are clusters of yellow dots. These are areas of the two cities that are predominantly white neighborhoods. And you can see, again, that in some of these areas, it's almost exclusively white neighborhoods. And in areas where, if you remember, where we had areas of concentrated poverty, where the redlining districts were, that's where today we have more people of color who are living in those neighborhoods. You know, there were other policies that happened that reinforced these patterns of segregation and created different opportunities for income and learning. For example, the GI Bill, which was signed in 1944, was really designed to help World War II veterans be able to thrive and prosper after the war. It's that legislation that was seen as a way to help build America's middle class. But because of things like housing covenants, some neighborhoods were just off limits to Black veterans coming back from war. Further, veterans who are Black who on paper could enroll in vocational training programs were denied that opportunity because of segregation of programs only being available to people who are white. And there's other kinds of policies that create investment or disinvestment in neighborhoods. For example, factories that create harmful chemical and air pollutants are often located in zoned areas that are closest to these redline districts, that are closest to these neighborhoods that are now areas of higher concentrations of poverty. Not in the more, there's a disproportionate number of people in these communities who are experiencing asthma, and now how asthma rates are associated with race and socioeconomic status. I want to give you just a couple more examples of how structural racism evident in multiple systems contributes to health inequities today. It seems really important and timely to think about the policies related to policing and incarceration. African Americans are more likely than whites to be arrested. Once arrested, they are more likely to be convicted. And once convicted, they are more likely to experience lengthy prison sentences. In Minnesota, in 2017, Black Minnesotans accounted for just over 5% of the population overall, but 34% of the state's prison population. And Native Americans counted for 1% of the population, but about 10% of Minnesota's prison population. So there's a number of factors that go into these disproportionate presence of Black and Indigenous people in our criminal justice system. There are policing practices that lead to more people being pulled over, which also influences arrest rates. There's differences in representation in court and harsher penalties for minor parole violations. According to the US Bureau of Criminal Justice Statistics, Black adults are 6 times as likely to be incarcerated than whites, and Hispanics are 3 times as likely. And one of the factors that really has contributed to this disproportionate presence of people of color in our criminal justice system has been the result of inequitable responses to drug offenses. We know that according to the ACLU, Black Americans were 3.7 times more likely to be arrested for marijuana use than people who are white. And having a criminal record has a number of different kinds of impact. It shifts employment opportunities and the ability to be able to earn income. It can create challenges being able to rent an apartment or purchase a home. It can exclude people from being able to have eligibility for certain types of benefits, or not having the right to vote any longer. In the new Jim Crow, Michelle Alexander describes the multiple policies and practices that lead to disparities in policing, arrests, and representation and sentencing. and talks about how this record prevents full integration into society as wires that form a cage. And again, all of these factors impact individuals in multiple ways, including disproportionately having poorer health outcomes. Now, I just want to tie this back to my earlier statement about socioeconomic status being a primary driver of health inequities. You know, the policies and practices that I mentioned are just a few examples of ways that opportunities for education and home ownership and employment opportunities have been denied for some members of our community. And this has created a notable wealth gap. And it creates, frankly, a starting point of privilege for people who are white, because they're able to pass down assets to the next generation. So in 2016, the median family net worth, which is kind of the total amount of assets, which might include property, retirement funds, savings, and subtracted any sort of ongoing debt that could be credit card debt or mortgage. You can see that white families tend to have more wealth than families who are Black, Latino, or families of other multiple races by a considerable amount. Given the world that we live in today, I also felt it was just important to tie this presentation directly to COVID-19, because that's another area where we so clearly see that differences in health outcomes are not happening individually. They're happening to groups of people and for multiple reasons. COVID-19 is just really the most recent example of the multiple ways that both overt and systemic racism results in poor health outcomes for Americans who are Black, Indigenous, and other communities of color. Now in Minnesota, right now, COVID death rates are highest among Minnesotans who are Black or Indigenous. This isn't the total number of people who have died. This is based on COVID-related deaths per 100,000 people through mid-September. And you can see here that the death rates for people who are Indigenous or Black are nearly twice as high as rates for people who are Latino or white in in Minnesota, excuse me. And again, there are multiple reasons that these disparities exist. Nationally, there's evidence of biased screening and treatment approaches. A national study found that African-American patients who reported symptoms of coughing and fever were less likely to be referred for COVID testing than patients who were white who reported similar symptoms. And testing is not as widely available as it needs to be. And there are certainly essential workers, including workers who by the nature of their jobs can't maintain social distancing. Well, self-pay testing sites are available for people who can't afford them. My colleagues at Wilder, who are involved with the Minnesota Compass Project, recently conducted an analysis of workers in Minnesota. And they found that while Black and Latino Minnesotans comprise about 8% of the workforce overall, they are much more represented in frontline industries such as healthcare and childcare, actually at nearly double that rate. And immigrant workers are also more likely to be working in frontline positions in transportation, cleaning of buildings, healthcare, and childcare. These tend to be lower wage jobs, often part-time and without benefits. These are jobs where remote work is not an option. Doing your work by Zoom call can't happen. And workers are faced with this impossible choice of protecting their own health versus earning money to financially support their household. Finally, as I described before, the connection between neighborhood location, air pollution, and asthma, well, these inequities are also contributing to now some groups being at higher risk of developing more serious COVID-related symptoms, such as people in lower income communities who have higher rates of asthma and then at greater risk of more serious illness. So as I move to close, there are three things that I wanted to make sure to leave you with today. The first is that health inequities are unjust differences in health outcomes. They are unacceptable. The second is that health is shaped by much, much more than just healthcare. And the third is that reducing health inequities requires that we acknowledge and work to address structural racism across multiple sectors. It's clear that we need more than a special program off to the side to think about how we reduce inequities. We need to advance structural change across multiple systems that influence health. And I recognize that that's incredibly daunting. And at the same time, I've been really heartened by organizations that are taking steps to make changes in their organizations in the work that I've been able to do with different groups. For example, Children's Minnesota, after gathering data about health outcomes through their community health assessment, talking with community members and convening a community advisory committee, they've identified structural racism explicitly as one of the health priorities that they're working on, and they're working with great intention on implementing meaningful change. I've had the opportunity to work with organizations like Appetite for Change in North Minneapolis that's working in the community and with community to create a more equitable food system that includes work to support local growers and to support local businesses. Now, the goal that we're working towards isn't just incremental change in reducing health inequities, but it's actually achieving health equity. And health equity is achieved when every person has the opportunity to receive their help, to realize their own health potential. And that is the highest level of health possible for that person, without limits that are imposed by structural inequities. To achieve health equity, it will take work across multiple systems. It will require changes in the criminal justice system, the educational system, how neighborhoods are planned and designed, economic investment opportunities. It also requires significant changes in who is at the table, because we know that too often leaders from the communities that are most impacted by structural racism and are disproportionately impacted by poorer health are not fully involved in shaping priorities, identifying solutions, and leading the work moving forward. So, what is your work? Both the challenge and the opportunity of working to advance health equity and address structural racism is that it includes so many sectors of action. So in some ways, your challenge is to find your lane, the area that you feel most passionate about, the place where you feel like you can commit, and decide what you can really bring to it. Speaking specifically to fellow white allies, we have work to do to better listen and follow people of color who have been leading this work. And frankly, we have a lot of work to do within our own racial community to educate one another about structural racism and to think about the ways that we are partners and working with intention to make changes to these systems. Some of the things that you can do, again, are thinking about the work that you're most passionate about in one of the multiple sectors that influence health. And know that some of a lane that you might work in could be giving presentations and sharing research, working really hard to advocate for state and federal policy changes, thinking about changes you can make within your own organization, providing financial support to organizations already doing great work, or finding ways to participate in protests. You don't have to do it all, but inaction is really the only thing that can't happen. So as I leave you today, I encourage you not just to think about what I've shared and look for an opportunity to learn more, read more, but to really be intentional in thinking about what your next step can be and to think about the lane that you're going to move forward in to reduce health inequities. Thanks.
Melanie, thank you so much. as a health care provider and a doctor, I see a lot of this. I'm at Hennepin County Medical Center, and I know Wilder and its data, and I've used it. But the way you integrated data to say, what is the foundation and what can it tell us about what's wrong, but more importantly, how we can move forward. I'm just very grateful. Thank you. Making it maybe a little more concrete, can you give a few examples of where you have seen individuals take this kind of knowledge and understanding and made something move forward? Doesn't have to be gigantic, but.
Yeah, let me give you a couple of examples. One is that in some conversation that I had with someone from a healthcare system, they recognized that they had lower vaccination rates for some of the communities of color that they were serving, and also noticed that they had more families who were going to the ER or emergency room for care than to the primary care doctor. What they ended up learning when they took a step back and really thought about, like, what's the system that's contributing to this, or, you know, what isn't working within our policies, they realized that they had a policy in place where you could only schedule appointments for so many people at the same time. And so for a person who's taking time off of work and wants to bring 3 kids in for an appointment, the hospitals or the healthcare system's policy to only be able to allow, you know, 2 appointments, for instance, to be scheduled at the same time to try to prevent the risk of no-shows, meant that that parent wasn't going to schedule 2 different kinds of policies. And so that system noticed that they were inadvertently creating a policy that was leading to a disincentive for families to get the preventative care that they need. And so I think that that's this good example of, you know, seeing data, noticing that there's something wrong. It seems like there's a disparity here, but then that work to keep peeling back to really understand what's causing it and be able to shift that system. I think that's a good example of doing the work to understand where structural racism actually is evident and had been having an unintentional impact on their patients of color.
Thank you. You did make me realize, as I said, I'm at HCMC, and in order to stay on schedule, we have policies about how late somebody can be. And I actually teach, so I'm with the residents. And one of the things that's clear to me is they're stressed with schedules, but it's been obvious that certain people have more transportation problems. And that population is likely to be later. And yet if we apply the same cutoff rule for how many minutes late you can be before you can be squeezed in. So, wow. Not that we need more data, but data helps when I'm talking to people and when we are all trying to do this. Will there be an update on this report? The original was 2010, and you referenced a lot of information from 2000 and the changes. Any word on an update?
There's no update planned, and, you know, I'll be honest, you know, I think as helpful as that report has been in at that point, really bringing attention to these inequities in health outcomes. You know, I think researchers, rightfully so, get a lot of pushback about spending a lot of time just admiring the problems that we have, rather than actually doing the work to make sure that solutions move forward. And so, you know, I would certainly be open to doing another kind of study like that, but I'm much more interested in, you know, what's the work that is happening within communities? What are the policy changes that can happen, and spending more time elevating those, or, you know, really being able to put those financial resources that would fund a study into the work that can happen in communities to address the problems that we know are there. I can guarantee we have not eliminated health inequities.
You talked about choosing your own area. When you and I talked, one of the things you said is find your passion. Maybe that was my choice of word. You here used, what lane are you in? I was very impressed when you said it before, and the point you made now, and that is most of us have an energy around something, and maybe that's something that bothers us more than others. And I really appreciated your saying it's not a matter of going out and, oh, this is the thing that needs to be done, although that's true, but what are you called to? Because that's where your energy would be. Shifting a little bit, we have large immigrant populations in the Twin Cities in particular, but also to some degree in broader Minnesota. Do you see any ways in which we need to be thinking differently? I almost hate to use that word because that's part of where bias comes in, but in relation to the broad immigrant distribution, and there's so many different cultures.
Yeah, well, and I think it is important to see difference, right? There's a lot of problems that occur when we try to say that we're colorblind. That isn't true, but it's seeing and respecting those differences and then working to, work across cultures. So I do think seeing differences is important. There is quite a bit of data that tends to show that when immigrants come to the United States, their health outcomes are better than the national averages. They are perhaps coming to the United States from a culture where they are eating healthier foods, they're getting more physical activity. And so I think that some of the things that we can be doing in creating opportunities for health for specific immigrant and refugee communities is really thinking about how living here can be a continuation of the healthy things that they had been doing in their original country. And, that can include things like, what kinds of food do we make available through our food shelves and distribution centers if there are people coming to the country who, for a while, that's how they're going to get more of their food. Like, how can we continue to make that healthy food available? Another thing that I think we just have to be really thoughtful and mindful in doing in all sectors is thinking about how are we building a workforce that is inclusive and includes individuals from the many countries where we have immigrant and refugee populations, and really thinking about the career pipelines for people who are then coming from other places. Because when our systems can't communicate well to the people who are newest to our community, there is going to be a disconnect. And I know that there's a lot of good work that's happening in that area, and there continues to be more that can be done.
Thank you. Again, you did say collecting more data isn't the key, but there are people who will want to read more, hear more, learn more. Do you have any resources that you recommend? And I'm going to particularly say, maybe this is directed toward me, when people give me a long reference, I lose track of it and don't find it. But are there easy references to get to, in a sense, through Google with some key words? And I know you mentioned MinPost. Maybe you can say what that report was about or that information.
Sure. With MinPost, I had, written a blog post about the importance of thinking about racism as a public health issue right now. And in that blog post, I did kind of highlight a number of other resources. I think part of it depends a little bit on the sector that most appeals to you in terms of where to go for good information. in terms of high-level demographic information, Minnesota Compass has that kind of information. There's also really great resources that are available to kind of give bite-sized information about what structural racism is. And I can perhaps follow up with a link to some of those resources so that you can share those more broadly. Sorry, I can't think of more examples just right off the top of my head for kind of good data points. Oh, you're on mute right now, Ken.
Thank you. In the report, you talked about relationships and how important those are. And you mentioned kind of levels, which if I have it right, one was bonding, another was linking, and I forget, and there was bonding, and then bonding was the more intimate family, close community. Bridging, which was folks that were linking around certain areas and activities, maybe like a broader neighborhood. And then there was the linking, which is a little bit more of the policy, people coming from very different perspectives, but trying to solve a problem. I just think relationships are so important, and clearly they're going to impact this. Can you say any more about, I'm not quite sure, what we do about it, how we impact it?
Yeah, there's a lot of good research that talks about how health is influenced by the connections that we have on multiple levels. Certainly we know that these feelings of isolation can lead to depression. And even if it isn't leading to depression, isolation can be a way of being cut off from resources or information that could be helpful to know to figure out how to access resources or supports that support your health or that you need in your life. And there's also good evidence that shows that the connections that we have with one another are incredibly important to supporting our health and well-being. So at this time, when we're all just kind of figuring out how to continue our lives in this social distancing reality, and by Zoom, I think there's a lot of creative things that have happened in terms of really identifying who may be feeling most cut off right now, and making sure that there's technology available so that people are able to connect. And I think it's really important as we think about advancing health equity that we're able to really recognize the strength that comes from strong communities, whether communities are defined geographically or ethnically, and really see that as an opportunity to be able to, really think about how that is a leverage point for supporting health, how those points of connection can be a way to make sure that, again, people who are potentially cut off from resources that can be more supportive do end up finding other information, and how strong networks, strong social groups can be leverage points for really strong and important advocacy that needs to happen in a number of these areas.
Thank you. We got one question about the Appetite for Change program in North Minneapolis. Can you say something about that, if you're aware of it?
Yeah, I've had the opportunity to work with them on and off for a few years. They really began just recognizing that in North Minneapolis, there were not many places available where residents could be able to buy and purchase healthy, affordable, fresh foods. And so this nonprofit organization has been really creative in how they have worked to be able to engage youth around more healthy eating and growing. They've worked to engage more farmers and think about ways that they can distribute food that has been grown locally to residents in different sorts of ways. They have had a restaurant in North Minneapolis, Breaking Bread Cafe. I'm not sure of their current status right now with everything related to COVID. But again, really thinking about both hiring residents who live in the community and making sure that healthy, fresh food is available then, to members of the community who live there. So I think, they're a really great organization taking a very holistic look at what it means to actually change a system from within the community. And I know that there are so many other examples of organizations taking that similar type of really holistic way of thinking about supporting health and changing systems, both in the Twin Cities Metro and in other parts of the state.
Thanks. Our church, Westminster Presbyterian, has been involved in housing for quite a long time. You clearly pointed out the impacts that go way back in terms of access to housing and that kind of thing. Can you speak to things that are being done that you see that either individuals, well, particularly that individuals can get involved in to try and move this really big, complex issue? I guess that's my question.
Yeah, and I'll give the disclaimer that housing is not my area of expertise. I think right now is a really challenging time. I feel like there was a lot of momentum, in the governor's office and, just among housing advocates overall, when it seemed like we had a budget surplus at the state level, to think about how we can invest that then into more affordable housing in the state. And that is no longer an easy strategy forward when we're faced with a just different budget reality under COVID. But certainly organizations like Beacon, the Minnesota Housing Fund, there's good work in trying to think strategically about how to be able to make more affordable housing available. And I guess I can't say more about specific initiatives to be involved with. I'm happy to talk with my colleagues who are more involved in housing though, and can, give a follow-up link if that'd be helpful.
Great, thank you. I am particularly involved with healthcare reform. I've known the percentage before, but I'm humbled when you showed the chart with the person standing there, and 20% or less of their health and well-being and function is due to the big industry that I'm involved in, which is delivering healthcare. Nonetheless, it's obviously a hot political item, and I think access is just profoundly important. Can you speak at all to health access or access to healthcare, health services? You touched on it, but anything else you want to say?
Yeah, I'll say a couple different things. One is, I think it is so, well, let me start by saying, Minnesota in some ways has always been a little bit out ahead of the curve, right? Thinking about ways to be able to expand eligibility so that more people can be able to access health insurance. And Minnesota has done that in a variety of different ways in the past. The work that happened through the ACA, I think, was critical in shifting what happened nationally so that we have more people across the nation who are able to be receiving healthcare through Medicaid, and that we got rid of restrictions that meant that people with pre-existing conditions wouldn't be able to get health insurance. And I think it's really critical that those types of reform measures are in place and continue to expand, because frankly, we can't contain healthcare costs by excluding people who have pre-existing conditions. We don't stop providing healthcare. They just come in a different door into our emergency departments with more significant healthcare needs, rather than being able to, identify issues early and be able to, treat and eliminate diseases. The other thing that is the more challenging part, we recently did a study that was for the United States of Care and its partners, thinking about what's the role of healthcare in addressing health inequities. And just some of the pragmatic challenges there are that the financing system for healthcare is really not set up to focus on keeping people well. A lot of our reimbursement models have to do with services that are provided. And so there's a disincentive right now with how our payment structures are in place to really make sure that providers are able to work to keep people well, that there's more creative work that can be done in partnership with social services and some of those types of things. I think we have really interesting and great demonstration projects that are happening, but to be able to take that to scale and do that more broadly, that's the healthcare reform that I would love to see, and that we can do parts of within the state, and there's innovation that can happen within systems. But some of that leadership is really at the top federal level that, needs to happen.
I'll just chime in a little bit on that. And in our present system, we pay so much better for procedures. If I've got appendicitis or a fractured arm, I want something done. I want it done well. But all the chronic diseases and the mental health issues that are just so critically important for an individual and a society to be well, those are not paid for well. So just the point that you were making. Let's see what else. The volunteerism in your report has actually decreased from 2000 to 2010. Any thoughts on that? And part of what we're saying here is people need to step forward, not necessarily in the space they're being paid. That shocked me and was disheartening.
Yeah, I would love to see, I should take a look at where we are right now with that data. Rates of volunteerism have tended to be higher among some of our older residents. But it does feel like we have a different, perhaps necessity for volunteerism that's happening right now. In some ways, I think there is perhaps a different necessity and energy that's happening now that we're all experiencing COVID, and there's been such disruption in the work lives for many people, and also people needing to depend on one another in different ways to make sure that they're able to, get the support that they need. So I do think looking at that as a way that we can come together, and I think that what volunteerism looks like moving forward also may be different as we continue to move through this pandemic together.
Well, Melanie and Ken, thank you both for a very interesting discussion, and for Melanie, especially for sharing your perspectives and insights. We greatly appreciate that. We'll continue this conversation in our next forum from a little bit different perspective, when we have two medical doctors locally and a mental health professional that are joining in to talk about the impacts of COVID-19 and health disparities in our community. Thank you all very much.